Good morning, dear students. Today we are going to discuss macrolides antibiotic from the general chemotherapy section. But before we proceed for the today's topic, let's have a look to this picture. Yes, COVID-19. We all are aware of this current global problem associated with COVID-19. And we also know about the preventive measures which are shown in this picture. So I request you all to follow these rules and contribute yourself in the prevention of COVID-19 from the community. Whenever we learn any antimicrobial agent, we can divide its discussion in various subheadings like history, chemical nature, classification, mechanism of action, development of drug resistance, spectrum of activity, pharmacokinetic parameters, adverse drug reactions, some important drug interactions, and therapeutic uses. Let us start with the history or introductory part. Erythromycin was discovered in 1952 by McGuire from a strain of Streptomyces erythraeus. Roxithromycin, clarithromycin, and azithromycin are semi-synthetic derivatives. Macrolide antibiotics contain macrocyclic lactone ring. All macrolides have 14-membered lactone ring while azithromycin has 15-membered ring. One or more deoxy sugars are attached with this lactone ring and hence the name given is macrolide. Let us see the classification of this group. Natural one, that is erythromycin, and clarithromycin, roxithromycin and azithromycin are semi-synthetic derivatives. Mechanism of action of this group. You have learned in one of the previous lectures regarding the protein synthesis. And this group interferes with protein synthesis in microorganisms. Primarily, macrolide antibiotics are bacteriostatic in nature, but in susceptible organisms at the higher concentration, they are bactericidal in nature. Macrolide antibiotics attach to the peptidyl site of the 50S portion of the bacterial ribosomes and inhibit protein synthesis. The particular step which is inhibited by this group, that is translocation during elongation of protein synthesis. They do not inhibit 60 and 40 subunits of mammalian cells and therefore exhibit selective toxicity principle. Mechanism of development of resistance. First one is drug efflux by an active pump mechanism. Second is modification of receptor sites on 50S ribosome which lead to decreased binding of the drug. And third is hydrolysis by erythromycin esterase enzyme which is produced by enterobacteria. Erythromycin is the prototype of this group. Let us discuss first erythromycin. Spectrum of activity of erythromycin. It is highly effective against organisms like Streptococcus pyogenes, Streptococcus pneumonia, Neisseria gonorrhea, Clostridia, Corynebacterium diphtheria, Listeria. In addition to these organisms, it is also effective against Campylobacter, Legionella, Bordetella catarrhalis, Mycoplasma which are not affected by penicillin. But erythromycin is not effective against penicillin resistant Staphylococcus and Streptococcus. Some organisms are moderately sensitive to erythromycin and these are Haemophilus ducreyi, Haemophilus influenza, Bordetella pertussis, Chlamydia trachomatis, Streptococcus viridans, Neisseria meningitidis and Rickettsia. Some organisms are resistant to erythromycin and these are Enterobacteria, Bacteroides fragilis and some other gram-negative bacilli. Pharmacokinetic parameters of erythromycin. Absorption part, it is acid labile, that means inactivated by gastric acid, and therefore it is to be given either in enteric coated tablets or with ester salts. Absorption is incomplete while food delays its absorption. Distribution part, widely distributed and 70 to 80% plasma protein bound. It doesn't cross the blood brain barrier, that means CSA penetration is poor. Metabolism, partly metabolized in liver. Excretion primarily occurs in bile. Therefore, no need of dose alteration in renal failure. Plasma half-life is about 1.5 hour, but it persists longer in tissues. Overall pharmacokinetics of all these three agents, azithromycin, clarithromycin and erythromycin. So route of administration can be given by oral route, can be given by injectable forms, doesn't penetrate into the CNS. Metabolites of erythromycin and azithromycin appear in bile, while clarithromycin appears in urine. Adverse drug reactions. First, gastrointestinal system, epigastric pain, nausea, anorexia are generally found in pediatric population after oral ingestion of erythromycin. Diarrhea occasionally reported. Diarrhea is because of stimulation of motilin receptors which lead to increased gastric emptying, and that lead to increased intestinal motility. Second is ototoxicity, that is usually found after very high dose of erythromycin, and that is reversible. Third is hypersensitivity reactions, skin disease, eosinophilia and fever infrequently reported. Another important hypersensitivity reaction is hepatitis with cholestatic jaundice that usually occur after 1 to 3 weeks treatment with histolate ester of erythromycin. Drug interactions. Erythromycin and clarithromycin lead to inhibition of CYP3A4 enzyme, which lead to increased concentration of drugs like theophylline, carbamazepine, cyclosporine, phenytoin, warfarin, digoxin, valproic acid, ergotamine. It also increased the concentration of drugs like terfenadine, estimazole and cisapride, which resulted into QT prolongation and serious ventricular arrhythmias. With azithromycin, no such drug interactions are reported. Therapeutic uses. Spectrum of activity of erythromycin is almost similar to penicillin, and therefore it can be used as an alternative to penicillin in those patients who are allergic to penicillin. Streptococcal pharyngitis, tonsillitis, mastoiditis, community acquired pneumonia are treated with erythromycin. Upper respiratory tract infections, the usual dose of erythromycin is 250 to 500 milligram every 6 hourly for 7 to 10 days. In diphtheria, antitoxin is the primary treatment, but for acute as well as carrier state, erythromycin is recommended for 7 days. In tetanus, erythromycin is used as an adjuvant to antitoxin as well as toxoid therapy. Other uses are syphilis and gonorrhea as well as leptospirosis. As a first choice, erythromycin can be used for atypical pneumonia, whooping cough and chancroid, and as second choice for Campylobacter enteritis, Legionnaires pneumonia and Chlamydia trachomatis. Let us see newer macrolide antibiotics. Why there is need of newer macrolides? So let us see first what are the drawbacks of erythromycin. Drawbacks or the limitations of erythromycin are narrow spectrum of activity, gastric intolerance, acid labile, low oral bioavailability, poor tissue penetration, and short plasma half-life. And therefore, these clarithromycin, roxithromycin, and azithromycin are introduced in place of erythromycin. These are the semi-synthetic derivatives of this group. Let us see first roxithromycin. It is a semi-synthetic, longer acting and acid stable macrolide. Almost similar efficacy like erythromycin but having better gastric tolerability. It having better oral absorption also, and its plasma half-life is long as compared to erythromycin, that is almost about 12 hours. So twice daily dosing is possible. So it can be used as an alternative to erythromycin for respiratory, ENT, skin and soft tissue as well as genital infections. Clarithromycin, similar spectrum of activity like erythromycin, but in addition to that, it is also effective against Mycobacterium avium complex, Mycobacterium leprae, and some anaerobes. But it is not effective against Bacteroides fragilis. It is more effective as compared to erythromycin against Helicobacter pylori, Mycoplasma pneumonia, Legionella, and Moraxella catarrhalis. It is absorbed rapidly from the gastrointestinal tract, more acid stable, can be given with or without food. That means food doesn't affect its absorption. Bioavailability is around 50 to 55%, although it having better absorption, but because it undergoes first pass metabolism and therefore bioavailability is low. It follows saturation kinetics. That means at the low dose level, its plasma half-life is around 4 to 6 hours, while at the higher dose, its plasma half-life increase up to 6 to 9 hours. It excreted through kidney. Clarithromycin can be used in various infections like upper respiratory tract infection and lower respiratory tract infections like sinusitis, otitis media, whooping cough, atypical pneumonia. Also for skin and soft tissue infections caused by Streptococcus pyogenes and Staphylococcus aureus. It is also part of triple drug regime used for eradication of H. pylori infection. It also used in the patients of AIDS with MAC infection, that is Mycobacterium avium complex, also used in leprosy. Third newer macrolide is azithromycin. It having extended spectrum of activity. It is more effective against Haemophilus influenza than other macrolides. High activity against particularly some respiratory pathogens, that is Mycoplasma pneumonia, Chlamydia pneumonia, Legionella, Moraxella catarrhalis, Chlamydia trachomatis, Haemophilus ducreyi, Neisseria gonorrhea, and also having good activity against Mycobacterium avium complex. It having another important advantage as compared to the other macrolides like improved pharmacokinetics, and that is acid stable, rapid oral absorption, extensive tissue distribution and penetration. That is the very important advantage of azithromycin, and slow release from the tissues, that it makes its long terminal half-life, that is almost about 50 hours, and therefore azithromycin can be used on once daily basis. It can be used as a first line drug for treatment of Legionnaires pneumonia, and the dosage is 500 mg once daily for 2 weeks. Chlamydia trachomatis infections, 1 gram single dose is effective. But in case of Legionella granuloma venereum, that is LGV, 3 weekly doses are required. For Sancroid, 1 gram single dose is sufficient. Donovanosis, 500 milligram once daily for 7 days. Some other infections for which azithromycin can be used are upper respiratory tract infection, community acquired pneumonia, Mycobacterium avium complex in AIDS, multi-drug resistance typhoid fever, and toxoplasmosis. Let us see the comparison of macrolides, erythromycin versus roxithromycin, clarithromycin, and azithromycin. Source: erythromycin natural, while others three are semi-synthetic derivatives. Spectrum of activity of erythromycin is narrow, while roxithromycin almost similar to erythromycin, and clarithromycin and azithromycin having expanded or extended spectrum of activity compared to erythromycin. If we consider pharmacokinetic parameters in the form of absorption part, incomplete oral absorption associated with erythromycin, while others three having good oral absorption. Acid lability with erythromycin, while others three are acid stable. Regarding the duration of action, erythromycin is shorter acting, and that's why it has to be given every 6 hourly. Roxithromycin can be given on twice daily basis, as well as clarithromycin also, while azithromycin is very longer acting and hence once daily administration is possible. Usual dosage range is for erythromycin it is 250 to 500 milligram every 6 hourly, roxithromycin 150 milligram twice daily, clarithromycin 250 milligram twice daily, while azithromycin 500 milligram once daily. Considering the drug interactions, we have learned this part earlier that erythromycin and clarithromycin inhibits CYP3A4 enzyme, and therefore drug interactions are usually found with erythromycin and clarithromycin, while in case of roxithromycin and azithromycin such drug interactions are rarely found. This is overall therapeutic uses of all the macrolide antibiotics. You can see various infections here and which macrolide is specifically used for that particular organism. It includes chlamydial infections, Corynebacterium diphtheria, Legionnaire disease, Mycoplasma pneumonia, syphilis. So that is all about macrolide antibiotics. Thank you so much. Stay safe, stay blessed.